In this lecture video, I will discuss about anti-epileptic drugs. The content of my lecture include timeline of anti-epileptic drugs, classification of anti-epileptic drugs, mechanism of action, and anti-epileptic drugs explained in the headings of mode of actions, side effects, therapeutic use, and anti-epileptic drugs used in special situations. Timeline of anti-epileptic drugs. This figure summarizes the various anti-epileptic drugs with the years of introductions. Bromide was the first compound having anti-epileptic property, was introduced way back in 1860. Then phenobarbital, which was the first used anti-epileptics clinically in 1912. Then we have the first generation anti-epileptics, which include phenytoin, corticosteroids, ACTH, primidone, methotrexate, ethosuximides. Then we have the second generation anti-epileptics, which include chlordiazepoxides, carbamazepine, valproates, clonazepams, and clobazams, which were introduced in 1960. Then we have the third generation anti-epileptics, which was introduced right from 90s, which include vigabatrin, zonisamide, oxcarbazepine, felvamads, gabapentin, topiramate, lacosamide, retigavins, everolimus, cannabidiol, and fenfluramines. We have this exhaustive list. We will discuss the mechanism of actions of these anti-epileptics as well as its therapeutic uses in detail in the coming lectures. Then mechanism of anti-epileptic drugs. This figure summarizes the mode of actions of anti-epileptic drugs. The drugs which acts on sodium channels and therefore have anti-epileptic property by inhibiting the hyperexcitability of the neurons, because sodium ion is responsible for generation of action potentials. Therefore, reduced entry of sodium ion into the neurons will lead to decreased hyperexcitability, decreased firing of the neurons, and thus it can have an anti-epileptic effects, which include phenytoin, carbamazepine, oxcarbamazepine, lamotrigine, lacosamide, zonisamide, and cenobamates. These are sodium channel blockers. Then we have synaptic vesicles 2A receptors blockers, which include levetiracetam and brivaracetam. Then we have calcium channel blockers, which include ethosuximides, which acts on the voltage gated ion calcium channels. Then retigavin, which are the potassium channel openers. Then NMDA receptors blockers, which include felvamates, valproates, and topiramate. Then AMPA receptors blockers, which include parampinols, phenobarbital. Then GABA-A receptors blockers, which include benzodiazepines, barbiturates, topiramates, strapentols, and cenobamates. Then we have the GABA transaminases inhibitors like vigabatrins. Then valproates also increases the GABA concentrations at the synaptic cleft by increasing the GABA turnover. Then we have the alpha to delta subunits of the calcium channels blockers, which include gabapentin and pregabalins. So these are the different antiepileptics drugs and their mode of action summarized in this figure. This is the figure in which there is entry of sodium ions through the sodium channels, leading to excitability of the neurons. These sodium channel blockers reduces the entry of sodium channels and therefore prevents the hyperexcitability of the neurons. These include carbamazepine, phenytoin, felbamate, lamotrigines, barbiturates and topiramates. So these are sodium channel blockers, reduces the entry of sodium ions through the channels, thereby having an anti-epileptic effects by reducing the hyperexcitability of the neurons. Then these are the calcium channels, voltage gated calcium channels, which is involved in generation of action potentials, and calcium channel antagonists like ethosuximides and valproates reduces the entry of calcium ion through these channels and prevents the hyperexcitability of the neurons. Then vigabattrins, which are the GABA transaminases inhibitors, prevents the degradations of GABA and therefore increases the concentrations of GABA at the synaptic cleft and thereby having an inhibitory effects. Benzodiazepine, barbiturates and topiramates have GABA antagonist actions, which GABA receptors blockers, thereby preventing the increases the frequency of chloride channels through the receptors, thereby producing an inhibitory effects over the neurons and prevents the hyperexcitability. Then AMPA receptors blockers, it has the AMPA receptors blockers prevents the glycine and glutamates to bind over the receptors and therefore prevents the entry of these ions like calcium ions and sodium ions through the channels and have an anti-epileptic effects by preventing the excitability of the neurons. Then mode of action of different anti-epileptic drugs. The calcium channel blockers that enhances the inactivations include lamotrigines, felbamate, oxcarbazepine, topiramate, lacosamide, phenytoin, rufinamides, cinvamates, jonisamides, valproic acids and carbamazepine. Then calcium channel blockers, which include lamotrigine, ethosuximide and valproic acid. Then alpha to delta ligands blockers, which include gabapentin and pregabalins, and potassium channel openers, which include retigabin. Drugs that enhances GABAergic transmissions and thus enhances the inhibitory neurotransmissions, which include GABA receptors allosteric modulators like felbamates, topiramates, oxcarbazepine, astrapentol, cannabidols and phenobarbitons. GABA uptake inhibitors, which include lamotrigines, stripentols and thiagabins, GABA transaminases inhibitors like vigabatrin, zonisamide and valproic acids, NMDA receptors antagonists like felvomets. Then drugs that have a selective post-synaptic inhibitions of excitatory neurotransmitters, and these include AMPA kinase receptors antagonist, which include topiramate and parampenols. Drug that enhances hyperpolarized cyclic nucleotide channels activity, that include lamotrigines, and another one that modulates the presynaptic mechanisms, that are synaptic vesicles 2A protein ligands, which include levetiracetam and brivaracetam. Drugs that have a inhibitory effects on brain carbonic anhydrases, that include topiramate and zonisamides. Now, the mode of actions of individual drugs. Phenobarbitons was first effectively used antiepileptics introduced in 1912. It enhances GABA A receptors mediated synaptic inhibitions. It has also GABA facilitatory, GABA mimetic, anti-glutamate and calcium ions blockers property. Phenytoins, which are diphenylhydatones, it was synthesized in 1908 as an barbiturates analogs. At therapeutic concentrations, it prolonged the inactivations of voltage-gated neuronal sodium channels, but at higher and toxic concentrations, it reduces calcium influx, inhibitions of glutamate, and facilitates GABA responses at the higher dose. Carbamazepine, which is chemically related to imipramine, it was introduced in 1960 for trigeminal neuralgia, and these are sodium channel blockers. Then valproic acids, which are sodium channel blockers, calcium channel blockers, as well as these augments the release of inhibitory neurotransmitters GABA A by inhibiting its degradations by acting on GABA transaminases, thereby have an inhibitory effects at the synaptic cleft. Then felvamates, which are the sodium channel blockers, it also potentiate GABA A mediated inhibitions and are antagonists at NMDA receptors. Then gabapentins, which modulates transmitter release by binding to alpha 2 delta subunits of the calcium channels. Lamotrigines, which blocks sodium channels as well as calcium channels, and so these are sodium and calcium channel blockers. Topiramates, these are the blockers or sodium and calcium channel blockers. Then thiagabins, which inhibits GABA reuptake by depressing the GABA transporters, whilst remove synaptically released GABA into the neurons and glial cells, that thus potentiate GABA mediated neuronal inhibitions. Levetiracetam, which modulates transmitter release by binding to alpha 2 delta subunits of the voltage gated calcium channels. Oxcarbazepines are the sodium channel and calcium channel blockers. Zonisamides are Sodium channel blockers, calcium channel blockers, it potentiate GABAergic neurotransmissions as well as inhibitors of carbonic anhydrases. Pregabalins are alpha 2 binds to alpha 2 delta 7 units of the voltage gated calcium channels, cause a decreased release of calciums at the nerve terminals. Lacosamide enhances are the sodium channel blockers. Carbazepines are also the sodium channel blockers. Retigavens are the potassium channel openers, thereby resulting in enhanced M currents, thus thereby stabilizing the resting membrane potentials. Ethosuximides are the calcium channel blockers. Brivacetams are structurally related to levetiracetam, and this binds to synaptic vesicles 2A and therefore thus prevents the release of the neurotransmitters. Vigabatrin irreversibly inhibits GABA transaminases, resulting in accumulations of GABA as well as positive modulators of GABA A receptors. Rufinamates are the sodium channel blockers. Parampinols are selective non-competitive AMPA glutamate receptors antagonist. Cannabidiol does not interact with the cannabinoids receptors and does not share the psychoactive property of the tetrahydrocannabinols. It enhances GABAergic activity through allosteric modulations of GABA A receptors and enhances the current elicited by low GABA A concentrations. Stripentols are the direct allosteric modulators of GABA A receptors, therefore prevents GABA reuptakes as well as positive modulators of GABA A receptors. Cenovamates blocks the sodium channels, there are sodium channel blockers as well as enhances GABAergic activity through allosteric modulations. Then side effects of the different antiepileptics. The most common side effect is sedation, fatigue and sleepiness, which are common with benzodiazepine, phenobarbital, topiramate, zonisamide and felbamates as well as rufinamides, pregabalin and tiagavins. Ataxia, vertigo and diplopia are common with carbamazepine, oxcarbazepine, phenytoin and lacosamides. Tremors, valproic acid, carbamazepine, oxcarbamazepine and phenytoin. Slow thinking and word finding problems is common with topiramate, zonisamide, phenobarbital and benzodiazepines. Insomnia with felbamates, vigabatrin and levetiracetam. Hyperactivity and inattentions is common with benzodiazepine, phenobarbital, levetiracetam and valproic acid. Irritability and behavioral problems with benzodiazepine, phenobarbital, levetiracetam and vigabatrins. Mood changes and depressions with levetiracetam, phenobarbital, benzodiazepine, vigabatrin, topiramate and zonisamide. Nausea and vomiting are common with felbamates, valproic acid, ethosuximide, oxcarbazepine, carbamazepine, lamotrigine, topiramate, zonisamide and rufinamides. Anorexia is common with topiramate, zonisamide and felbamates. Increased appetite with valproic acid, clobazams, pregabalin and cannabidiol. Headache with rufinamides, levetiracetam, lamotrigine, oxcarbazepine, and lacosamide. Hyponatremia is common with oxcarbazepine and carbamazepine. Urinary hesitancy and retention with retigabine. Metabolic acidosis with topiramate and zonisamide. Reduced bone mineral density with phenobarbital, primidone, phenytoin, carbamazepine, valproic acid, and oxcarbamazepine. Allergic rashes and Stevens-Johnson syndrome is common with lamotrigine, phenytoin, phenobarbital, carbamazepine, oxcarbamazepine, rufinamide, and ethosuximide. Hepatic failure is common with valproic acid and felvamates. Pancreatitis with valproic acids. Aplastic anemia with felvamate, carbamazepine, phenytoin, phenobarbital, and ethosuximide. Cardiac arrhythmia, rufinamates lead to shortened QT interval and lacosamide prolonged QT intervals. Nephrolithiasis is common with topiramate and zonisamide. Angle closure glaucoma is common with topiramate. Irreversible peripheral field defect is common with vigabatrin, and blurred vision with perampanels. Psychiatric side effect like suicides is the black burning of all anti-epileptic drugs. Worsening of rare inborn error of metabolism is common with valproic acid. Polycystic ovarian syndrome is common with valproic acid. Teratogenicity is highest risk with valproic acid and phenytoins. Dress syndrome is common with cenobamates. Then uses of anti-epileptic drugs. The anti-epileptic drugs which is used in generalized tonic-clonic, simple partial with or without generalizations include carbamazepine, phenytoin, valproates, phenobarbital, lamotrigines, gabapentin, topiramate, primidone, levetiracetam, retigabine, tiagabine, lacosamide, and zonisamides. For complex partial with or without generalizations, carbamazepine, valproates, phenytoin, gabapentin, lamotrigine, levetiracetam, clovazams, zonisamide, and topiramates. For absence seizure, the drugs include valproates, ethosuximides, lamotrigines, clovazams, and clonazepams. For myoclonic seizures, the drugs include valproates, lamotrigines, topiramates, levetiracetam, and clonazepams. For atonic seizures, valproates, clonazepams, clovazams, and lamotrigines. Febrile seizures, diazepams. Status epilepticus, lorazepam, diazepams, fosphenytoin, phenobarbitons, as well as general anesthesia. For focal seizures, focal onset seizures like cenobamates. Juvenile myoclonic epilepsy, juvenile absence epilepsy, or epilepsy with generalized tonic-clonic seizures, the drugs used are valproic acids, lamotrigine, levetiracetam, topiramate, zonisamides, and benzodiazepines. For childhood absence epilepsy, the drugs include ethosuximide, valproic acid, and lamotrigines. For genetic epilepsy with febrile seizure, the drugs that can be used are levetiracetam, lamotrigines and valproic acids. For Lennox-Gastaut syndromes, myoclonic atonic epilepsy, focal or structural as well as metabolic causes or unknown etiology, as well as in West syndrome, the antiepileptics that can be used to manage are valproic acid, lamotrigines, topiramate, clobazams, rofenamides, carbamazepine, levetiracetam, valproic acid, ACTH, high dose of steroids, vigabatrin, cannabidiol and felvamides. So these drugs can be used for the management of these types of epilepsy. That epilepsy with continuous spikes, wave in sleep or Landau-Kleffner syndromes, the antiepileptics that can be used are levetiracetam, high dose of diazepams and steroids. Dravet syndromes, valproic acid, benzodiazepine, topiramate, strapentols and cannabidiols. Infantile spasm, vigabatrin and ACTH. Trigeminal neuralgia, carbamazepine, oxcarbamazepine and lamotrigines. Mania and bipolar, primidone, topiramate and valproic acids. Panic attacks, valproic acids. Migraine, valproic acid, topiramate and gabapentins. Tuberous sclerosis, vigabatrin and cannabidiols. Post-herpetic neuralgia, gabapentins and pregabalins. Fibromyalgia and generalized anxiety disorders, pregabalin, tiagabins and valproic acids. Alcoholic withdrawal seizures, phenobarbitons, phenytoin, tiagabins and oxcarbazepines. In wing eating disorders, zonisamide and topiramate can be used to manage. Then antiepileptics in patients with epilepsy and other comorbidities and systemic diseases. Then how we will decide about the use of these antiepileptics if the patient is having seizures along with other comorbidities like liver diseases, kidney disease, or is taking oral contraceptives, or is overweight or underweight, if he is pregnant. Then how we will manage such patients, which type of antiepileptics you will prefer in these conditions, in these cases. So antiepileptic drugs to be avoided or considered when the patient is taking an oral contraceptives. So we should avoid these enzymes inducing antiepileptic drugs. These include carbamazepine, felvamides, lamotrigine, oxcarbazepine, phenobarbital, phenytoin, primidones and topiramate. These are the enzymes inducers, so should be avoided if the patient is taking oral contraceptives, because it can lead to failure of the oral contraceptives. So these non-enzyme inducing antiepileptic drugs should be preferred in these patients. These include ethosuximide, gabapentin, levetiracetam, pregabalin, tiagabins, valproates, vigabatrin, zonisamide and benzodiazepines. This flowchart summarizes the antiepileptics having teratogenic property. Here we can see that valproates have highest teratogenicity. Other include carbamazepine and topiramate, as well as phenytoin and phenobarbital. These have the intermediate teratogenicity, whereas gabapentin, levetiracetam, clonazepams and lamotrigines have the lowest teratogenic effects. So these drugs can be preferred in pregnancy. Here you can also see that the logistic regressions of fetal malformations risk on antiepileptic drugs. Here we can see that levetiracetam have the lowest risk, whereas valproates have the highest risk of fetal malformations. These are some of the articles which summarizes the teratogenicity of the antiepileptic drugs. Here we can see that valproates have 99.3% teratogenicity, phenobarbital 5.3% teratogenicity. In another article, the teratogenicity of lamotrigine, oxcarbazepine, gabapentin, topiramate and bear 3.2% and lamotrigines have 3.7% teratogenicity. And in another article on the teratogenicity of newer antiepileptics, valproates have 16.3% of the teratogenicity. In this table explains the antiepileptic drugs which requires the dose modifications in the patients with kidney diseases. Here we can see that carbamazepine, oxcarbazepine, lamotrigines, ethosuximide and benzodiazepine does not need dose modifications in the patients with kidney diseases. So, these drugs can be preferred in CKD patients requiring an antiepileptics, whereas phenytoin, phenobarbital, valproates, gabapentin, topiramate, vigabatrin and levetiracetam requires the dose modifications in the patients with kidney diseases. This table summarizes the different antiepileptics which are predominantly metabolized by liver, and so in a patients with liver diseases, these drugs which are predominantly metabolized by liver should be avoided. These include benzodiazepine, carbamazepine, ethosuximide, felbamate, lamotrigine, oxcarbazepine, phenobarbital, phenytoin, tiagavins and valproates, whereas the drugs which have the extrahepatic metabolisms like gabapentin and vigabatrins can be preferred in the patients with liver diseases, whereas the drugs like levetiracetam, topiramate and zonisamide are partially metabolized by liver, so can be used with a dose modification. Then antiepileptics in overweight and underweight patients. Here carbamazepine, oxcarbazepine, gabapentin, pregabalin, sodium valproates and vigabatrin lead to weight gain. So, these drugs should be avoided in overweight patients, whereas felbamate, topiramate, zonisamide and strapentols lead to weight loss. So, these drugs should be avoided in underweight patients, whereas lamotrigine and levetiracetam, phenytoin, tiagavins and laicosamides have no effects on the weight. So, these drugs can be preferred in overweight as well as in underweight patients. Then we can see the different antiepileptics which can decrease the bone mineralization like phenytoin, phenobarbital and primidones as well as valproic acids, whereas lamotrigines, gabapentin and levetiracetam are safe in a sense that this does not decreases the bone mineralizations. Then enzyme inducing antiepileptics that can exacerbate the symptoms of porphyria, which include carbamazepine, phenobarbital, phenytoin, valproates, topiramates, as well as lamotrigine and tiagavins also have the porphyrogenic activities. So, these drugs should be avoided in a porphyria patients, whereas non-enzyme inducing antiepileptics like gabapentin, levetiracetam and pregabalins are usually recommended in these patients. In liver transplant patient, levetiracetam and topiramate are preferred, whereas in kidney transplant patient, lamotrigines and valproic acids are preferred, whereas in bone marrow transplant patient, levetiracetams, lamotrigines and tropiramates are preferred antiepileptics. Then psychotropic effects of the different antiepileptics which have a positive effect on the mood, that is mood stabilizing properties, include lamotrigines, carbamazepine, valproates, gabapentin and pregabalins, whereas the negative effect, that is lead to aggressions and irritabilities like levetiracetam's. Depressions is common with barbiturates, and effects on psychoactive symptoms like positive symptoms and negative effects like psychosis, psychosis is common with triagabins. This table summarizes the different antiepileptics which should be used in a patients with epilepsy with other comorbidities. Thank you all for watching my lecture. Do subscribe to my channel for more and regular updates on interesting topic of the medical science. Thank you.